I'm really excited to introduce Casey Vogel, who's a physical therapist at Lurie Children's Hospital. She works both in their ICU and acute care units as well as with their neurodevelopmental team. And she's going to be talking with us today about some of the really unique programs that she's building around caring for inpatients who are currently on the transplant waitlist.
Thank you, Jesse, for giving me this opportunity. And then I also just want to give Mike a shout out, as he was my professor, and then he was also my internship supervisor, and he helped give me my start. So thank you for this opportunity to present training for transplant. These are some of the objectives that I do hope to review today. And what do you want to do with your new card?
Go home.
Go home? What are you going to do at home?
Just run around.
So each year nationally, there's about 350 to 390 pediatric heart transplants that are completed, and the most updated numbers for this are actually closer to about 500. But overall, pediatric heart transplants only make up about 10% of the total heart transplant volume, making this overall pretty understudied cohort of patients. Our outcomes do continue to improve over time, but many of our patients are requiring additional transplants over the course of their lifespan, and our waitlist mortality is still definitely present. At Lurie, we complete about 20 to 30 heart transplants a year, with about 60 to 70% of those being patients with congenital heart disease, as compared to the national average, which is about 45%. We do anticipate also at Lurie that almost 50% of our patients will be bridged to transplant with some sort of a VAD. So this brings me up to what is the ideal vision for acute care delivery. And in my opinion, it should be to optimize mobility and to provide developmentally appropriate care for critically ill patients, including those on mechanical support. But there are definitely barriers to doing so. Some of that is medical equipment, the baseline level of function that patients present with for surgery. So are there things that we could be doing to prehab those patients or put them in a little bit of a better position going into surgery? I think communication among staff, and then also most importantly, a culture shift to accept exercise as medicine and the need for mobility and activity to be viewed as a priority. I think we're all kind of familiar with the signs and symptoms of heart failure, but these include fatigue, activity intolerance, orthopnea, increased work of breathing, nausea, vomiting, palpitations, feeding intolerance, and for our patients with congenital heart disease, desaturation. And while our goal is this picture on the left, I think it's really hard for our parents to get away from, and even some of our providers, from this view of our patients of being these fragile kids. And it's not uncommon when I show up and try to explain what I'm going to do that the parents say, do you know that my patient or that my child is admitted here for a heart transplant? So it's really important that we partner with our parents to emphasize why what we're doing is important. It's also important when we're working with our patients with congenital heart disease to recognize the pattern of neurodevelopmental and behavioral dysfunction. So these are some of the common characteristics, which include mild cognitive impairment, impaired social interaction, impairments in core communication, visual construction and perception deficits. About 50% of our patients will have some sort of an attention deficit, impulsive behavior, executive dysfunction, and fine and gross motor deficits. So it's not necessarily as easy as just providing a simple exercise prescription. We need to really consider all of these different factors when we're bringing together our plan. And also, Katie went over this data yesterday, but it's also important to consider that about 20 to 40% of our patients with congenital heart disease will have some sort of motor delay across their lifespan. So when they're being admitted for transplant, they're sometimes that much further behind the 8 ball than some of our other patients, so we really have our work cut out for us. In 2020, the American Physical Therapy Association published this clinical practice guideline for the management of individuals with heart failure. And today we're going to talk about how, while this was originally intended for the adult population, I do think there are some key pieces that we can bring over to the pediatric setting. One of the first things that it really nicely outlines for is that we do need to be doing exercise in this population. It is really important. One is important to just go ahead and when do we need to kind of pump the brakes. But if our patients are asymptomatic, they should be exercising. It is really important for this population. But if our patients are starting to develop symptoms, if they're starting to gain some weight, starting to cough more, having more swelling, being more short of breath, it is important that we're following up with our medical team about this and potentially considering how we're going to change some of the exercises. And then I think we all know if our patients are presenting with significant symptoms, they can't catch their breath, they need to sleep totally upright, they have significant weight gain, this is a time when we're potentially just shifting to if they're in the hospital, can we just get them up to the chair, things like that. But in order to do that, it is important to establish baseline and regular tracking to assist with the identification of patient progress, plateau, or regression. The other thing that this CPG does is it really nicely outlines what types of activity they have been found to be most effective when working with patients with heart failure. So we'll dive more into this today. But what is the goal when we're developing our program? From a physical therapy perspective, for our patients who are waiting for a heart transplant, my goal is to improve the patient's strength and endurance leading up to transplant. We really believe that the stronger our patients are going into transplant, the better they're going to do on the other side. So if we put in that prehab work, it makes the post-transplant recovery that much easier. So if our patients are stable medically and developmentally, our patients work with physical therapy 2 times a week, and then they work with our exercise physiologists led by Katie Bashina and Dr. Kendra Ward 3 times per week. If the patients are starting to become less stable, if they're immediately post-surgical, or if they've had an event, they're just working with physical therapy and at a higher frequency. And our discharge goal for all of our patients, hopefully, is that they participate in our outpatient cardiac rehab program with our exercise physiologists. What do we measure? I think this is a question I got asked last week. All of our patients on admission, we complete a 6-minute walk test and a 30-second chair rise. And then every 2 weeks, we alternate that testing. So we always have a test within a week of where we're at, and especially going into transplant. So we keep a really close eye on how our patients are doing. But what about our younger kids? What do we do with them? Honestly, you're going to see today that our program is pretty similar for them. We want to improve our strength and endurance leading up to transplant while also progressing their developmental motor skills. Our stable patients we see 2 to 3 times a week, and like I talked about before, if they're a little bit more medically complex, then we see them at a higher frequency. In addition to completing, if our patients can walk and follow directions, we get a 6-minute walk test done on them as well. But it's also important to assess their overall motor skills. So at Lurie, we have decided to complete the Day C for our patients 0 to 4 years of age. This allows us to also partner with our speech colleagues and occupational therapy to keep a close eye on how they're doing developmentally throughout their admission, with the hope that this hospital admission is not a huge setback to their overall development. And then for our patients who are 4 all the way up through 21, we can complete the BOT. We do the BOT short form, and this is important because this is the same test that we complete in our school-age neurodevelopmental clinic. So we're able to keep a really close eye on the kids throughout the course of their lifespan. So the first thing that this CPG recommends is that we advocate for increased total daily physical activity as an essential component of care. And I think we know the AHA guidelines recommend at least 60 minutes per day of moderate to vigorous activity. They want 3 days a week of vigorous activity and 3 days a week of strengthening activities. But how does this work if you're in the hospital? So for all of our patients who are admitted greater than 30 days, or we're expecting at least a 30-day admission, we develop these activity goals, which get posted both at bedside. So our families, patients, parents, everyone's aware of what the expectation is. And then we also put them in the EMR. So it is expected that they are participating in school, that they're doing their ADLs, hopefully out of bed, that they are getting up to the chair for their meals, and that they're going on at least 5 walks a day. So they're not just sitting in their room waiting for all of their medical teams to come to them. So that's easy for your older kids. But how does this translate to our younger kids? So I think this is like one of my favorite studies. And it shows that the average toddler who's 12 to 19 months of age walks about 2,400 steps per hour, which is about 8 football fields. And we see that it's in all different directions. It's not just like this linear path. And they also fall 17 times an hour because they're learning how to balance. So over the course of a waking day, this adds up to 14,000 steps, 46 football fields, and 100 falls. But you can see how the predicted hospital movement experience can be quite different than what we would expect. So it is really important that we are partnering with our medical teams to develop a plan of care that goes at bedside. And I do believe that your program also does this here at Michigan, but we insert the toddler and our younger kids' individual pictures because the parents get really excited about it, our nurses get excited about it. I think it draws more attention to it, but we try to identify what developmentally appropriate activities for these individual kids that we can be doing with them outside of therapy. So moving on to aerobic activity, the CPG advocates that our patients are participating in aerobic activity and also high intensity interval training. So again, starting with our older kids in the hospital, you can do this by just walking the halls or going on the treadmill. I personally have found that our patients are more engaged if I get them doing aerobic interval training. So you can do this. When we started our program, we did not have a gym on our unit. We now do. So I started it with just, I had a 100-foot hallway. I have them speed walk, jog, whatever they can do down the hallway one way, and then they slowly walk back so they get that active recovery in. And I'm able to track the total time that they're able to participate in exercise, how fast they're doing, and how many repetitions. And you can do a similar thing, obviously, on the treadmill. We utilize 1-minute intervals. I am not a fan of utilizing the stationary bike necessarily in this population, just considering their overall bone health. So it is really important that we are loading these patients' bones, especially our transplant patients who are going to be dosed with diuretics and with steroids as part of their medical treatment. But I will utilize the bike if they are tethered to equipment, like this patient over here. He's stuck on CRT, so then I'm able to bring the bike into his room so that he is able to bike and participate in aerobic activity despite his medical equipment. So there are a couple different opportunities where we will utilize our bike, or if our patients are not yet strong enough to walk, I will get them on a bike so that they can still participate in aerobic activity. But what about the younger kids? It's not, again, it's going to be pretty similar. Taking them for walks. We have a little shopping cart they get pretty excited about. They set up scavenger hunts around the hallways. But getting our younger kids who have much longer wait times engaged in walking around the unit for months on end sometimes is a little bit more challenging. So we will get these kids out on bikes. We allow our kids to bring in their bikes from home if they put their training wheels back on it. We have a couple tricycles for the unit, and then we have worked with the Marquette engineering students to make some bikes for our patients with bats. How do you do interval training with the younger kids? This is one example of one of our patients, and we set up, again, utilizing that 100-foot hallway. We have the patients run down the hallway and then slow walk back. Ideally, when you're working on developing a program, I think it would be nice if you saw the number of repetitions they did increased over time and that your recovery times were a little bit different. But you can see overall with this patient that initially her running speeds were at about 22 seconds when we started working with her, and we were able to cut that in half leading up to transplant. And this is what this looks like. You can see that's our transplant director in the back. He's on a scooter racing her. We get all of our nurses, physicians, parents get involved, and it does make it pretty fun for the kids. So moving on to resistance training, that's also going to be an important piece. And I think probably with this population, even a more important piece, knowing that they are about to get dosed with steroids, which impact your proximal muscle strength. So with our older kids, I feel like as soon as they're listed for transplant, if they're close to adult size, I just have this like clock that's going off in my head. I only have a couple of weeks to a month to get them as strong as they can be, knowing that they're probably going to be transplanted faster. So for this group, I really focus on lower body strengthening with squats, sit-to-stands, step-up variations. Some of our patients are able to progress to lunges, and if they can tolerate lying flat, bridges, and hamstring curls. But I want them to be able to get out of bed as fast as possible after transplant. So this is where I focus more of my resistance training. With younger kids, it ends up being pretty similar. We just have to make it a little bit more play-based. You can see here she's doing some tall kneeling, working on ball play. Pre-COVID, we had a yoga program that all of our kids and their parents were able to participate in, which we do need to bring back. But the younger kids can do the same sorts of activities. They can do step-ups. You can set up activities that they're doing squats. Ball play squigs are a great way to get them to do heel raises to reach up higher, squats to reach down lower. And then the slide is also a great way to work on floor to stand transfers and get repeated step-ups in. And it's also an activity that they would be doing at home. So I think the parents get pretty excited about it too. Another big piece that the CPG advocates for is actually the use of inspiratory muscle trainers. And I've not been able to convince our staff to purchase me inspiratory muscle trainers. I continue to work on it. So in the meantime, we're just working on addressing our overall respiratory mechanics. So all of our patients do utilize incentive spirometry so that I can keep track of what volume they are able to achieve. But we also work on a lot of other pieces. So we work on postural re-education for our patients who have had multiple sternotomies. They have that protracted forward shoulders, increased kyphosis. So we work on getting them into a more neutral position so that they can take bigger, deeper breaths. We also work on trunk mobility. I think that was also mentioned yesterday. A lot of our patients who've had repeat sternotomies have a much more rigid trunk. So we work on pairing their breathing with certain movement, working on trunk rotation, and then also core strength is another really important piece of overall respiratory mechanics. And again, same thing, our younger kids can work on similar activities. We also work on postural re-education with them, trunk mobility, core strength. We can also add in additional strategies with voicing, which is where you count how long a patient can hold a consonant. So you count how long they can say like, ah, and you can track that objectively over time, or we can utilize bubbles with them. So overall, in each session, from a physical therapy standpoint, we try to include one activity that's gonna work on breathing mechanics, one activity that's gonna work on lower extremity strengthening, something aerobic, and then we're gonna try to continue with parent education, why it's important that the kids stay active now, and then also what the post-transplant mobility expectations are going to be. And our younger kids, again, it's going to be a pretty similar program. So how does this all piece together? We're going to go through a couple of case studies now. So the first one is a 19-month-old female with a history of hypoplastic left heart syndrome. She had undergone a Norwood and McGlenn at an outside hospital, and she was admitted to us due to progressive right ventricle dysfunction, failure to thrive, and activity intolerance. She was implanted with a VAD after being considered PDMAX 2. So initially post VAD implant, we completed the DAISY on her, and you can see her scores here. She was doing okay. Gross motor was definitely bringing in the rear, so we had some work cut out for us. But over the course of her prolonged hospitalization, she was able to make pretty significant progress. And I do feel like overall, we tried to prevent this hospitalization, again, from being a huge setback for her mobility and development. And by the time August hit, she was actually average in every single category. So we'd finally gotten gross motor into that average category. I think then real life hits. So she was successfully transplanted. She was cross-match positive at the time of transplant. So did require a little bit more intensive medical therapies initially. So you can see how her scores did change. And also she had some of those post-transplant blues. She was a little bit more withdrawn, really only was very clingy to mom. So her scores did drop initially at discharge, but she was able to successfully walk out of the hospital. And we just recommended follow-up with outpatient therapies. And today she's definitely back on track. Her gross motor skills are better than they've ever been. She's doing quite well overall. Her biggest deficit right now is they haven't gotten her totally potty trained yet. That's an additional section for adaptive functioning. But I think overall, this is a nice success story of a patient from a neurodevelopmental profile would be considered to be pretty high risk, but we were able to get her on a nice trajectory. So moving on to a 5-year-old with a history of hypoplastic left heart syndrome. This patient was the start of us bringing our cardiac rehab program down to our younger kids. She had a pretty significant past medical history. She had already undergone a Norwood, Glenn. She had a VFib arrest with ECMO, tricuspid valve repair. She did have a stroke at one point. She had undergone a Fontan and a pacemaker replacement, and she was admitted to our hospital due to PLE. When we first met her, she was severely deconditioned, very weak. She could only walk about 200 feet at a time, and on the bot, she was scoring in the first percentile, well below average. But over the course of her hospitalization, again, we were able to make pretty significant progress. So she improved from the first percentile up to the 8th percentile. And you can see how her 6-minute walk test distances also increase, as did her running speeds. The nice thing is that we are able to track our patients over time, so she continues to follow in our school-age neurodevelopmental clinic. You can see that her first neurodevelopmental clinic visit, she had dropped her BOT scores overall, but she is now on a more positive trajectory, and you can see how her 6-minute walk test distances have continued to improve. One of the big things with her case that I learned was her mom commented on that many of the activities we were working on in the hospital, she had never allowed her to do at home. She had allowed the siblings to do it, but mom was like, why is her balance so bad? And I was like, well, have you ever let her fall? And she's like, no. She would literally follow her around the house and make sure that she wasn't falling. She didn't sign her up for activities the same as the siblings. And I think she mentioned that she learned a lot from this hospitalization. And after she went home, she was able to pick up and let her do more of those activities. And this is her getting her first hit at baseball. So finally, moving on to one of our adolescent case studies. This is a 13-year-old male who was admitted to us with recently diagnosed dilated cardiomyopathy. He had no significant past medical history. He had actually just completed in the fall a round of competitive soccer. And he was admitted for heart transplant evaluation due to severely depressed heart function. When we met him, we completed his 6-minute walk test. He walked 1,420 feet, which for our patients who are admitted, I would say this is pretty average for our patients with heart failure. And we initiated that above ground aerobic interval training with him. The first day he was able to complete about 4 total minutes. Despite us continuing to work with him, 2 weeks later, his 6-minute walk test had decreased to 1,294 feet. And his over aerobic interval training volumes had also decreased. And in the background, our team attempted to wean him off epi. He developed pulsus alternans. He was starting to gain more weight, and his labs were getting worse. So overall, if we think back to this chart, he's starting to develop more symptoms. So I put him in this kind of yellow category. His parents had a really hard time. Like he was sitting there walking around, he was eating. So it was really hard for them to recognize how sick he was. They could not really wrap their heads around the fact that they had this son who had been playing competitive soccer 2 months before, and our team's telling him how sick he was. And we were able to utilize some of that exercise data to show 2 weeks ago he could do this. Now he can only do this. And that was more objective for them than some of the lab values were. So that was what convinced them that he did need a VAD. He was considered to be PDMAX 2. He was implanted with a HeartMate 3 and then also temporary RVAD support with a Protect Duo like Spark. Despite having 2 VADs, we were able to mobilize him. The FSSICU is a mobility score that scores how much help you need to get out of bed, to walk, to go up and down the stairs. So you can see that his score improved over time, despite having both devices. And you can also see how his distance walked improved. His first day of getting up, I told you he was a soccer player. His dad brought a soccer ball and insisted that we continue working on the soccer skills. We didn't want him to get too far behind. This graph shows where we started at. He had that slide, we implanted the VADs. Post RVAD support after it was explanted, we completed a 6-minute walk test the next day, and you can see that it had continued to slide. I think that's multifactorial. His body had undergone significant catabolic response. Also, there was probably some level of deconditioning in that in order to walk with him with all the equipment it had, it took a lot of people. So he didn't necessarily have the same opportunities. But just 2 weeks later, you can see how much better he was doing with his 6-minute walk test. And then we were able to engage our exercise physiologists, and he was participating in our full inpatient cardiac rehab program. He was discharged with his VAD, and then he continued to participate with our exercise physiologists in our outpatient cardiac rehab program. And I do feel like overall that really set him up for success for his transplant. So post-op day 1, we got up to the chair. Post-op day 2, he was able to walk over 500 feet. By post-op day 7, you can see a 6-minute walk test was almost as high as it had ever been, and he was successfully discharged by post-op day 14 with follow-up in our outpatient cardiac rehab program. So in summary, I do think that training for transplant may help improve post-transplant outcomes, but we do need to be creative and flexible when tracking outcomes. One outcome measure is not necessarily going to work in all scenarios, and then we do need to closely monitor our patient outcomes because it may be helpful with identifying the need for additional medical support. And what do you want to do with your new car?
Go home.
Go home? What are you going to do at home?
Just run around.
So I do think that is important to remember. Our kids just want to be kids, and I do think that we are uniquely positioned to allow our kids to be kids in the hospital to then set them up for success when they go home.